Jaundice, know the cause. Persistent jaundice in the neonatal period. A presentation by Dr. Amy Cutler. You are preparing to see an 18-day-old infant for a bilirubin check after mom stopped breastfeeding for a few days. History of present illness. The patient is an Asian infant born at 39 weeks gestation. He required treatment with phototherapy from days of life 2 through 5 for neonatal hyperbilirubinemia with presumed etiology physiologic jaundice. He was discharged home with outpatient follow-up bilirubins. The bilirubins remain below treatment level, but the patient remains jaundice. He has been eating Similac sensitive since mom temporarily stopped breastfeeding to see if it affected the bilirubin level. Your pertinent positives are jaundice. Your pertinent negatives are normal newborn metabolic screen, good weight gain, normal appearing and number of stools, and appropriate number of voids per day. Your diagnostic workup included the following labs: G6PD, bilirubin, CBC, Redic, LFTs, free T4, TSH, UGT1.128. Lab pertinent positives are an elevated bilirubin and positive UDIT, 1.28 variant. What are you thinking? The first differential diagnosis that comes to your mind is breast milk jaundice. The onset is 1 to 2 weeks of life. The occurrence is 20 to 30% of breastfed infants. Jaundice can persist for 8 to 12 weeks. The exact mechanism of etiology is unknown. It is thought that the substances in human milk inhibit the ability of the infant's liver to process bilirubin. It is also thought there may be a UGT1.8A1 mutation. This differential diagnosis falls with the correct onset timing and is a consideration. However, since the bilirubin remains elevated after the temporary cessation of breast milk intake, the diagnosis is eliminated. Of note, some providers suggest that interruption of breast milk intake is not necessary, as the bilirubin level will naturally decrease over time. The second differential diagnosis you think of is G6PD. The onset can present as neonatal hyperbilirubinemia, acute hemolysis, or asymptomatic. Occurrence is 5% of the world population. It is the most common enzyme deficiency worldwide. Etiology is an X-linked inherited disorder that most commonly affects male persons of African, Asian, Mediterranean, or Middle Eastern descent. Hyperbilirubinemia, ethnicity, and biological gender make this a consideration, but the lack of hemolysis makes this diagnosis less likely. The third thing you think of is congenital hypothyroidism. The onset of congenital hypothyroidism is slow and can take months to years to diagnose. Newborn metabolic screens with prompt follow-up now allow us to diagnose within neonatal period. It occurs 1 in 2,000 births. It most often affects females than males at a ratio of 1.5 or 2 to 1. Symptoms include prolonged jaundice, umbilical hernia, large or delayed closure of fontanelles, macroglossia, and constipation. Jaundice can last up to 3 weeks. The etiology of congenital hypothyroidism is the delay in the development of the uridine diphosphate glucuronosyl transferase enzyme, which is essential for bilirubin processing by the liver. It also causes slowed intestinal peristalsis and excretion of bilirubin through stool. Congenital hypothyroidism should be considered for any infant with prolonged jaundice, even if the newborn metabolic screen is normal. A normal exam, stooling pattern, and thyroid labs allow us to exclude this as a diagnosis. Your brain is getting tired, but you know you need rule out a surgical cause. You add biliary atresia to your list of differential diagnoses. Onset is a few weeks after birth. Occurrence is 1 in 12,000 to 15,000 U.S. births. The occurrence is also impacted by ethnicity. The occurrence rate is 1 in 8,000 Asian babies. It is the most common in African American babies. Biologic gender also affect occurrence. It is more common in females than males. Symptoms include persistent jaundice, pale stools, dark urine, hepatomegaly, and splenomegaly. Etiology is the blockage or damage of the bile ducts that carry bile from the liver to the intestines. Persistent jaundice and timing make this a consideration, but a normal exam, stools, and urine make this diagnosis unlikely. You had just done a lunch and learn on persistent jaundice and decided to include Gilbert syndrome in your list of differential diagnoses, even though it was an unlikely diagnosis. Gilbert syndrome can present from birth, but often presents in adolescence because of the increased bilirubin production in puberty. Occurrence is 3 to 7% worldwide, with a prevalence of 5 to 10% in men and 2 to 5% in women. It is most common in Caucasians and Asians. Symptoms include jaundice, fatigue, weakness, and abdominal pain. These symptoms can be triggered by fasting, infection, and stress. Etiology is a genetic mutation in the UGT1A1.2.8 enzyme that interferes with bilirubin conversion to bile. And your diagnosis is Gilbert syndrome, the persistent elevated unconjugated bilirubin, biological male gender, Asian descent, positive UGT1A1.2.8 variant. Support this diagnosis. It is a fairly benign condition. No treatment is needed except for lifestyle adjustments. Bilirubin usually returns to normal levels within 10 to 14 days after birth. Patient education will include avoiding prolonged fasting, managing stress, and drinking plenty of fluids. Avoid drugs that could worsen symptoms or interact with liver. Drug examples include Tylenol, HIV and cholesterol-lowering drugs because they inhibit the UGT enzyme, penicillins, cephalosporins, NSAIDs, and chemotherapy drugs because they impair RBC breakdown. Avoid supplements and foods high in vitamins A and D and niacin during flare-ups because they can increase bilirubin levels, and statins because of an increased risk of intolerance and myopathy.